next talk is by Vijayaraghavan, sir.
Really great talk by doctor, and stress the importance of taking blood pressure when you say case of bilateral papilledema. Never send the patient to neurologist immediately. You take BP and then you can send the patient. Otherwise you will be cutting a sorry figure. That's the most important aspect of our talk, I feel. Thank you very much.
Vijayaraghavan, sir. After leaving the army, he was a HOD at the Coimbatore Medical College, from where he retired. He's a passionate teacher, as those of us who know him, and his teaching is very close to his heart. He continues his teaching after retirement from Coimbatore Medical College. He is a visiting postgraduate teacher at Arvind Eye Hospital, Coimbatore, Madurai, Shankara Eye Institutions, the Eye Foundation, Coimbatore, and he has won several awards for his teaching, including the C.P. Gupta Award, the Joseph Jnanadikam Oration Award, all for his teaching abilities. Over to you, sir. Sir is going to speak to us about visual fields in neuro-ophthalmology.
Thank you very much, sir. I think some of my old PGs are sitting here. I feel very happy, and really it's something, give me something boost. I'm getting more boost so that I can give something I can tell. As a PG, we will pass in exams, defined field. Your answer is, we are looking straight, at the same time is an area is there in which we can see objects same time, simultaneously. That is called field of vision. When you take a uniocular field extent, superior nasal 60, below 70, and temporals 100. This is what uniocular. But normally, we are not going to close our eye and go. So naturally, both eyes are open. Horizontally, we have got about 220 degrees, and vertically about 120 degrees. That is the extent of field we are going to see with the binocular. Here, one important point I would like to tell. Suppose a person has come with a one eye for a driving license. The most important thing is what? When you see the extent of field in one eye, that is, if it is 140 degrees horizontally, you can give driving license, you can give, provided one eye is there, he is having a horizontal extent of fields about 140 degrees and above. That's enough. This is what I want to stress the importance. This is what it has been practiced in UK and all. Now another important point, as you trace the retina, from upper retina the fibers start, right or whatever left eye. They have to maintain upper relation only throughout the system. They cannot come down. Same thing, upper nasal means they have to remain upper only. Lower nasal means they have to remain lower only. They cannot change. No, in chiasma you got crossings. In the crossing what nasal fibers are crossing, agreed. But once you come to tract onwards, you will tell now here peripheral fibers, central fibers, like that we tell. Peripheral means what now? Same side temporal, same opposite side nasal. That's called peripheral fibers. Now here also we tell what? Upper temporal, upper nasal, lower temporal, lower nasal. That means from tract onwards you have to call like that only. That means either peripheral fibers or central fibers or uniocular fibers. What is uniocular? That's already Professor told. We have got extreme 1 millimeter of nasal retina has got no corresponding temporal retina. That is crossing in chiasma and can get something is getting work. It goes to occipital lobe, anterior tip. So till that time it's called uniocular fibers. We call it as uniocular. So starting from tract onwards, we call upper peripheral, lower peripheral, upper macular, lower macular, central, and upper uniocular, lower uniocular. That's all you are supposed to know. I already told you. That means what? The upper fibers, they have to maintain upper relation only. That means when you go to parietal lobe is naturally higher level. So parietal lobe gets the upper fibers only. The temporal lobe is lower, so naturally the fibers, visual fibers of lower aspect, they have to go to lower fiber, temporal only. Everyone knows, when the lower fiber is involved, you get upper field defects. When the upper fiber is involved, lower field defects, that's all, very simple. When you have a temporal lobe lesion, it's lower, so naturally the upper field defects, everyone knows that. Always remember, from tract onwards, you get homonymous. Right eye, left eye, both eyes have field defects, but same side, same area. That is called parietal lobe, upper, so naturally upper fibers, lower field defects, pie on the floor, pie on the, everything, that, everyone knows. Now, I already told you, nasal retinal crossing completely in the chiasma, and starting from chiasma onwards, if you take the fields, they will respect the vertical meridian. It's a dictum, you are supposed to know. The vertical meridian is respected when chiasma onwards. Suppose you got a retinal lesion is there, the vertical meridian of the field will not be respected. They can cross. That's the most important point as far as visual pathway is concerned. Now, I told you nasal fibers are crossing in chiasma. When the nasal fibers are crossing in chiasma, you can see that here. You can see it. Okay, you can see that the lower nasal and upper nasal, they don't cross just like that. The lower nasal fibers, after crossing, you can see that the blue line, after crossing, enters the opposite optic nerve, makes a bend called anterior genu of the Wilbrand, then come down. The upper nasal fibers, once before crossing, they enter your optic tract for 1 or 2 millimeter, then crosses and come to my opposite tract. Understand now? This all always remember. Lower nasal fibers make a bend in the opposite optic nerve. That is what important for us. That means what? When you have a lesion involving your optic nerve junction to chiasma, that area, not only the same optic nerve, the lower nasal of opposite is there. So naturally the lower nasal is involved means what? Upper temporal defect will be there in the other eye. That is why that the diagnostic, we can pinch or clinch the diagnosis or clinch the site of lesion. For example, I tell you, we have got anterior cerebral artery is there. Anterior cerebral artery crossing in that area. When you have an aneurysm of that anterior cerebral artery, you can have a compression there. So naturally when I take a fields, I have a field defect of one eye optic nerve problem is there. Maybe central scotoma or blindness, whatever thing is there. Other eye, if it shows upper temporal defect, I know the problem is somewhere in the junction. So I have to suspect and further investigation, that's all. So that's what fields, is like a mathematics. Always you can always clinch. It's not difficult. Here also same thing, can you see the anterior genu? It is shown there. From the right eye, it crosses to the left side. Then one more thing, we have got we are drawing a vertical line via the macula. So the macula itself we divide into temporal macula, nasal macula. Just remember this. The nasal macula fibers also cross in chiasma. See, the entire nasal is going to cross in chiasma. The nasal macula is crossing in chiasma. The beauty is what? Now the nasal macula fibers from both sides, they cross chiasma in the posterior aspect. So that's why when you have a lesion, imagine now, the posterior part of the chiasma when is compressed, the nasal macula alone may be damaged instead of other fibers. That means what? When the nasal macula means what? Temporal field defect, know that. And that too what? Macula means central. So I can have a bitemporal scotomas. So what is the question? No, we got posterior part of chiasma is involved. I can have a field defect of central scotoma. That's the beauty. That two central means what? Bitemporal, both eyes. Bitemporal hemianopix central scotoma area. That is why it's called as chiasma in chiasma. The fibers of nasal fibers crossing in chiasma is called as chiasma in chiasma. Another chiasma is there inside. I told you uniocular fibers are extreme nasal fibers. I already told you it ends in the anterior tip of calcarean fissure. Now, few definitions. Just for example, what is hemianopia? Involvement of suppose I am telling now upper, lower, upper, lower. We cannot have this side, right upper, left lower. You cannot have it. See, there are quadrants only. But you cannot have a hemianopia to call. They should involve contiguous quadrants. Upper, lower, lower. It cannot be this side upper, this side lower. Like this, you cannot, that means exactly corresponding. You cannot have this. That is called hemianopia, means to define involvement of contiguous quadrants. Homonymous means what? Same side. Suppose right area, left eye also same way, that's called homonymous. Heteronomous means what? Right eye right, left eye left. That means what? Bitemporal hemianopia. These are all heteronymous. These are the words you are supposed to know. See now here it's called right side is not seen. That's called right hemianopia. Right eye, always remember, right, whatever picture is shown belongs to right eye. So right eye hemianopia is there. I already told you, upper, lower. So it's hemianopia involving contiguous quadrants. Now we see here now. See now we have got right side, right. Here also left and left. There are two pictures. We call it as right side homonymous or left side homonymous. That's all. Hemianopia. Of course, one half is gone. Heteronymous, I already told you. Bitemporal hemianopia. You can see this. Or binasal hemianopia. These are all what? When you have a heteronymous defects, you know, you can close your eye and tell it's a chiasma area, that's all. Heteronymous can occur mainly in chiasma. But we have got one thing called pseudo-bitemporal. Pseudo-bitemporal, that means similar to bitemporal, but not respecting vertical meridian. That can occur where? This is what the question for PGs I used to ask. Your answer should be, sir, it can be classically, first now, you know. Forgotten, first now. You don't know. Sure. Pseudo-bitemporal hemianopia can occur where? You don't know. Just I will tell you, of course, nobody will ask you questions. For fun only, I'm a first now student, that's why I ask the questions. Okay? I will tell you later. First now, don't worry. Other hemianopias, altitudinal hemianopias, that means upper altitudinal, lower altitudinal, everything. But altitudinal hemianopias can occur where? Classically, ischemic optic neuropathies. Altitudinal hemianopia can occur in anterior ischemic optic neuropathy. But there are so many connections, just remember now, one of the most important points is this, that's all. Can I say now, upper altitudinal, lower altitudinal? Okay, next we have got now, see now, this called right homonymous hemianopia. You see now the centered area, macular splitting and macular sparing. Macular splitting is where? Tract. Macular sparing is where? Occipital lobe, that's all. Now they will ask you, as a PG, you know, they may ask you, why do you get macular sparing? Your answer should be, sir, by double blood supply to the macula. One is middle cerebral, another is posterior cerebral. And then bilateral representation. If you are able to that, as a PG, if you are able to tell that, that's enough for us. So these are all the reasons for your sparing. This is called equal amount, congruous. Here also you see now, upper picture, left side homonymous, congruous, equal amount. When you tell congruous means equal amount of fibers from both eyes are involved. It has to be occipital lobe only. When you have incongruous, the next look at picture you can see, right eye more, left eye less. That means what? It is incongruous. Incongruous means it's just a tract, that's all. Like that you can easily come to a conclusion just by noting this. Here is now, first now. Can you tell me is it congruous or incongruous? See, it's a fully developed field defect. Never call congruous. Only when you tell developing field defect, you can call it as congruous and incongruous. Once it has developed fully, we cannot call it congruous because during development how it is, you do not know. Now we can tell only macular splitting. When a macular splitting, is there a tract lesion? It's a tract lesion. In the tract I can have only incongruous. One occipital lobe only you can have congruous. Now we see the macular splitting is there, just that means during development would have been incongruous, that's all. So never tell a fully developed defects like this. This is what right eye junction of optic nerve chiasma. You see now, right eye central scotoma, left eye upper temporal defects. Same thing. I told you, remember, anterior cerebral artery aneurysms. Now it's of course bitemporal hemianopias. I told you chiasma and chiasma. I told you, remember now, this is what bitemporal hemianopia central scotomas. You can see now, central scotoma is there, only temporal half in right and left eye. This is called temporal half, small half is there. That is called bitemporal hemianopia central scotomas. And depends upon the chiasma also you can have, depends upon the position of chiasma to pituitary relation. You can have pre-chiasma, something I got, post-fixed, prefixed like that. The problem may vary. Sometimes I can have optic neuritis, optic no problem like this in chiasma, pituitary lesions. Sometimes I can have a problem of optic tract lesions, depends upon whether it is prefixed or postfixed. That's why whenever you see a case of central scotoma or whatever thing is there, optic nerve involvement, never forget to take MRI of pituitary area because we do not know the relation of chiasma to the pituitary. So always remember, it may be a case of pituitary tumor, you may be missing. That's why even when you have optic nerve problems, never forget to take an MRI of whatever chiasma and all. You must know pituitary relation also. This call I told you, incongruous. This is incongruous. Hello. First now, this is called right side homonymous, incongruous macular splitting. LGB, I can have a homonymous hemianopia also. Sometimes one is septar can be involved. It's called sectoronopia, one sector. LGB is a classical, no, we have got upper, middle, lower. Upper part supplied by one artery. The middle part is supplied by another artery. So if a problem of one artery is getting up, one part alone can be damaged. That's why you can have sector anopia. LGB can have a homonymous sector anopias. Like this, we got company center area. That means I will tell you here. So left sided, homonymous, sector anopia. That's all. Where is the lesion now? Maybe the central part of LGV, where the macular fibers are there. That's all. How, which artery is supplied? Always remember the macular fibers in LGV supplied by posterior cerebral artery. When that fellow is defected, you can have a problem of this. This is called pie in the sky phenomenon. You know that? It's a temporal oblations. It's a parietal oblations. Macular sparing, I told you, occipital oblations. A tubular vision can occur even, never forget, apart from so many causes, we can have bilateral occipital oblations. No, bilateral means what? Right occipital oblation is there. We have left homonymous is the macular sparing, left occipital, right homonymous is the macular sparing. Two macular sparings are there. It's the center area. I can have a tubular visions. So tubular vision can also occur in bilateral occipital oblations with macular sparing. That's all. This is called double homonymous myopia. It's called double homonymous myopias. This is called temporal crescent. We got, I told you, the extreme nasal fibers, anterior tip of calcaneal fissure, when they involve, I can have a unilateral field defects. That's all. One eye field defects. Normally, you know that one eye field defect occurs means what? Maybe in the retina, the optic nerve. But here is one area, the anterior tip of calcaneal fissure is involved. I can have one eye field defect. That means the nasal retina alone, the temporal, this is called temporal crescent, which is taken care of by nasal fibers. That can be involved. That means unilateral field defect can also occur in posterior part of your occipital base, that anterior part of occipital lesions. Understand now? This is what the important point. This is called as, each time, you know, the extended field changes. When you have it's called spiral fields. A spiral field occurs means it has to be hysterical. Okay, understand now? This is what regarding fields. I hope you understood something. Thank you very much.
Thank you very much.